a little reminder of the principles, which just, give us that sort of basis, I think, to help organisations do that assessment and assurance against making sure that the carer is at the heart of the service provision. And that was my sort of quick update, really.
Okay. So shall I just say a bit about what's happened since the event then? It was, I can't remember, was it October?
It was October 12th.
Yeah. So I work closely with Marianne anyway, because we kind of share an office here as a kind of, we're East Berkshire CCGs. I've been kind of taking a slough lead, Marianne on behalf of Windsor and Maidenhead, but we work obviously closely with our local authority colleagues. But what we wanted to do, on the back of the enthusiasm of the event, was really, we got together as a East Berkshire kind of group to say, well, what actually could we be doing better together to, with a more, integrated approach. Just it kind of informally, as I say, as the people that attended. So there was a lot of discussion around the principles, and also about the memorandum of understanding and how we might want to kind of take that forward, which we think is a useful kind of I don't know, kind of statement of commitment that we can kind of refer back to if we get the partners kind of on board with that. But we really wanted to hang something off it as a collaborative group, saying as part of this, wanted to take a more integrated approach, identifying 3 key areas that we wanted to do together. So those were really about firstly identifying carers in the acute setting. So it was part of, we thought perhaps initially part of just kind of admission and discharge planning.
Okay.
And then in GP and primary care services, because I think we all recognise that's still an issue for us, and also I think nationally, that GP identification of carers is still relatively low, or at least registering them and formal identification. Mm-hmm. And the other bit was really about young carers. So we thought, well, okay, in order to kind of get some kind of agreement and some traction on this, we went where should we go and speak to our kind of senior leaders? So we went to there's a new Vision of Care board, which is a new. Have you heard of that, Kath? A new Vision. It's really our I suppose what might be a frailty pathway, but an in principle description of, I suppose, what we would want to see from our system through the various stages of care and support that people need, from self-care and prevention through to acute and on to end of life. So there's a board that's kind of sat around that, which has the kind of probably the key people that we needed to influence and discuss with. So they were quite. We talked to them about the event. We talked to them about the memorandum of understanding and how we wanted to kind of take forward these 3 areas, and they were very supportive. But
sorry,
so some of the, yeah.
Can I just this Vision of Care board? Who convenes that?
Well, there's who convenes it? There's a kind of program management office that supports that work. Oh, Marion's joined us.
Well,
Marianne.
Hi, Marion. Can you hear me? No, I can see her, but she's not. I can't hear you yet, Marion. Shall I carry on for a moment?
Yeah,
yes, please. Yes. Yeah.
So yes, I was just saying about the new Vision of Care board, Kath. So yes, it's got representatives from our community and acute providers and social care, senior social care managers.
Who chairs it?
Who chairs it?
Yeah.
I'm trying to cast my mind back. Who chairs the meeting? Marion, do you know who normally chairs it?
It's normally Nick Davis.
I don't think you were at this one, but I can't remember, Kath, but I'll let you know.
Okay.
I'll give you, because there's terms of reference, I can give you the membership. We basically said we need to warm up the partners about this before it goes to our Health and Wellbeing Board.
Yeah.
We don't just want to go to the Health and Wellbeing Board, this is a kind of fait accompli and this is what we're doing. We kind of wanted to get people on board, before that stage. So, and this was where this, sorry. It was felt that this was probably the best group in which to kind of start that discussion.
Yeah. Okay.
So saying that, all kind of positive support for it, but in fact, a few comments that came back. One was, if we're focusing on the acute, don't just focus on the admission and discharge. It needs to be throughout the hospital, which, is fair enough. And the other one was, don't forget, community health services and mental health. So we. Okay, can you hear me still?
Yeah.
Can you all hear me?
Yeah.
So we've kind of got back together as a group and said, yes, that's great. We do acknowledge that it needs to be kind of need to kind of take it forward across those areas of service as well. But we're now kind of thinking we need to start somewhere. And I think if we're trying to do it all at once, then we're kind of setting ourselves up to fail.
Mm-hmm.
But so we do need to pick off some priority areas and how we're going to and then we'll phase in some other areas as we go forward. What we've done also kind of to try and get some patient participation. We've this week gone and met with a patient panel that convenes twice a year. So Marion, myself, and my colleague Sally Kitson from the local authority kind of presented some background and context to what we were trying to do for carers, and just to, if we could get a group of carers on board, because I think we want to kind of co-produce something with them, bringing forward some ideas that came forward from the event, asking for their ideas and input, and this is really particularly focusing on the identification and awareness in GP and primary care.
Mm-hmm.
And we've had quite an enthusiastic response actually from that. So we do a kind of pitch to the panel with our ideas, and then they have opportunity to come and approach us afterwards and learn a bit more about what it's about and what the commitment might be. And we had quite a good response from people, didn't we, Marion?
Yeah, absolutely.
Can you hear me?
I can't hear. Sorry.
You can't hear?
No. Oh, can you hear me now?
I can hear you now, yeah.
Oh, great. Okay, so I've been fiddling around I had a hard drive issue last week on my laptop, and I have been struggling to make connection with you, but if you can hear now, that's great.
Yes, I can,
That's fun. We can hear and see you. Thank you. I'm not
Brilliant.
how, by the way, and you obviously know Kath and Mike.
Good. So, Marion, I was just explaining about where the patient panel this week, and tried to rally some support from that group to kind of co-design, a project with us to how we might, better raise awareness, share good practice, and really, improve our achievements, I suppose, on identifying carers.
Yeah. I think that one of the great values of working through the patient panel is that it's an East Berkshire-wide program of work that's supported actually by the head of quality, Sarah Bellas.
Yeah.
So it means that it's raising the profile of carers actually across the piece. And as Sarah sits on the kind of top team that includes finance and operational delivery, it's really making sure that the carers agenda is actually now being an integral part at that level of discussion, and reinforcing the importance of resident feedback. So for us, it was kind of both ends of the opportunity in terms of engaging with the public and the residents, but also making sure that we were doing something that would have the right profile, and that's why it was such a good opportunity.
Excellent.
Kath, do you want to, just I'm chipping in here, do you want to just mention our practice manager we had on a similar call on Tuesday, looking at primary care, because that's both just mentioned that.
Okay, no, that would be really useful.
Well, it was, I mean, I think what we're getting is the opportunity to hear some really proactive and positive developments with, I mean, just linking to your work, Marion, it's about getting carers on the agenda in the right way from a quality perspective, but also from a co-design perspective. And I think to have that sort of strategic and on the ground to go at this is just fantastic. And I think what we can do as well, I think, is link this up with where we're picking up some pockets of really good, exciting progress and practice as well. So Jane Isaac was on the WebEx on Tuesday. She's from a GP practice in Swindon, and I think
it's Bath, isn't it? Doesn't matter, but I think it's Bath.
Oh,
Jane Isaac.
Oh, it is Bath. Why about Swindon? Sorry, it's Oldfield, isn't it? Oldfield practice.
Yeah. Very interesting.
And she is steering some very proactive and productive stuff with regards to carers. And it's interesting because it highlights that it's, you know, the practice manager, if they have a bit of a passion and a bit of a belief in making sure that carers are on the agenda, then it drives that practice in, you know, so much faster and with you know, that commitment, I think, really. So she's giving examples of how she's trying to get the practice to be signed up to be a dementia friend practice. They have just they've just done a piece of work around working on how to reduce DNA appointments. And one idea they've adopted is that they've written out to all carers to ask if they would be happy to have their mobile telephone number put onto the records, so that and to consent that they would receive a text message when the person they care for has a GP appointment as a reminder as well. And so by having consent that if they're seeing a reduction in DNAs, because that the person with the appointment is having that extra reminder from the carer to make sure they go to that appointment. Yeah. So that was just one little idea.
Yeah.
We talked as well a bit about needing a sort of a carer process map from the GP in terms of what happens when you are identified as a carer and what support is there and how that can be ensured as a sort of a pathway of care. I think those are the main things that came out.
Could I just add something in there, please? Coincidentally, the chair of our Windsor, Ascot and Maidenhead CCG, their practice recently went through a CQC review. And although they got a lot of ticks in lots of boxes, one of the areas that they needed a lot more support in delivering a better standard was the identification and support for carers. So there's an opportunity, and I shared this with Mike briefly yesterday, that one of the things that they're really looking to do is to pilot a carer feedback review mechanism that says not only, you know, I've been identified and I've been offered all of these services, but what difference is it actually making to me, so that we're actually being able to not just do lots of stuff, but actually identify the things that make more or less difference for different groups of carers. Because a young carer would have a very different experience in terms of added value than, say, a carer for somebody with long-term conditions. So the WAMCCG Chair's practice I met with last night, and they have agreed to actually pilot this service user carer feedback mechanism on behalf of their own practice in the first instance, but then share the experience much more widely, not only into our East Berkshire initiative actually, but more widely as well. So that would be really well informed by the kind of good experience and ideas from the practice manager that you've just described, but also being able to reciprocate with some feedback about that evaluation tool.
That sounds brilliant, Marion. Can I just ask, who's written the feedback mechanism? Is that yourself?
No, it's actually a further development of an existing toolkit by a recognised organisation that's done a lot of evaluation and feedback stuff, particularly in the southeast, called R Outcomes. They've done a lot of work around evaluating the benefits of social prescribing, and we talked to them actually, because we're also piloting another aspect of that feedback mechanism with our short-term support and rehab team here, and we were talking to them about the care homes program, about the carers project, and they said that they would be very interested in using the opportunity to pilot the feedback tool that they're developing for carers. And so it's a recognised organisation, and this is an additional tool to what they're already doing.
Fantastic. Because I'm just wondering how that can link in as well to a little piece of work that NHS England is doing in piloting with a few GP practices across South Central, an opportunity to look at carer indicators. And this ties in with CQC in that what we know, because we work quite closely with CQC, and what we do know is that when CQC go in, they're clearly experts in their field, but they have communicated to us that when it comes down to the PPP and the responsive domain and identifying and supporting carers, it's not their absolute area of expertise, and they don't have sort of goalposts or targets to know what it is they should be exactly looking for. And it's helping us think about how we can work with GP practices to support better use and more effective use of the carers register in one instance. So what read codes are being used and how are they being used, and actually how is the practice really effectively utilising that carer register so that it is pulling up, they can read codes in so that they can identify how many young carers they have, how many carers of people with mental health problems, how many carers of people with dementia, and so on. I don't know if every CCG is different, but I know in Gloucestershire, for example, there are 99 read codes with the carers register, which seems a lot.
It is a difficulty, and last financial year, we focused on the identification of more carers in relation to one of our NHS England quality premium targets, and it was a great idea, and we delivered a big uplift in the number of carers identified. But I have to say, hand on heart, the read code issue that was so different across the different practices did really create a challenge for us in terms of doing a before and after evidence base, if you like, that says, this is how they're being identified on a consistent basis across all of the WAM practices. So the work that you're describing, we would be very interested in knowing more about and contributing to. And the Runnymede practice that I've just mentioned,
we're working really closely with Runnymede with the oversight.
Right, okay. So that's the practice, and the reason why we picked Runnymede is that they're in the invidious position of actually being based in WAM, Windsor, Ascot and Maidenhead from a CCG perspective, but the majority of their patients are actually registered in Surrey. So it's the cross-correlation between the provision of support services for Surrey residents who are carers that actually needs to link really closely into their identification within the practice in WAM CCG. So that's why this cross-boundary working is a really important aspect of what we're doing.
Interesting. And is there a branch in Surrey?
Sorry, say that again?
They have a branch practice. Is that actually physically in Surrey?
No, they don't. The other branch practice that they have is also in Windsor, Ascot and Maidenhead in Old Windsor in Newton Court. So both practices are based in WAM, but the majority of their Runnymede patients are actually resident in Surrey.
Right.
Can I just briefly sort of intervene around the read code team, because I did some work in primary care quite a long time ago around long-term conditions and also around access, and I've found in the past that if you find the GP in the in the CCG area, there's often a GP IT pioneer, somebody who's either got to read it or has taken it on themselves. For example, to develop ENIS templates is one of the things I've come across in South Gloucestershire, and it's those kind of people that often, want to get it right around read codes and could actually lead some recommendations and advice within the whole CCG area about how to record in order to, as you say, in order to be accurate about whether the list is an appropriate size or increasing. So just an idea there that, as you probably all know, using the enthusiasm of a kind of information IT type lead GP, not in the practice, but in the whole CCG area, can just get them.
I don't know if Mike wants to come in here, because we talked about actually the importance of the identification of a clinical lead for this program of work, Mike.
Yeah. Well, so we are going. We want to get a technical lead identified. But I'm just thinking, Marion, that maybe someone like Rishi might be able to help on that IT front. He's have an interest.
I think that Rishi is the right person from the point of view of enthusiasm and characteristics, but he's so tied up in the development of the digital route map.
No, I don't mean
I'm afraid that this would be yet another burden on an already exhaustive list of activities.
No, I don't mean by that, but I mean just in terms of the possibilities, because he knows, the system and how it works and how GPs use it. So just from that perspective, he might be able to give us some pointers.
Good idea.
We seek to get.
I think he would definitely be the right person, but I don't think he's got much capacity over above
to take it on. No, and I wouldn't expect that.
So I wonder if there is something there that we can support this with in terms of, because to me there's something around making sense that there's some consistency about the carers register within a GP practice, and that consistency then lends itself to agreed read codes that are manageable and beneficial and not overburdensome. And I'd be really interested to think about how we can support that. So, for example, if we could be saying, across in South Central as a starting point for the South, that there was a bit of work done with IT whizzes and with evidence base that we already have about what read codes are useful and others, and that we could get a consensus so that you've got confidence that all the GP practices within your patch are all signing to that same sheet.
I think that would be a very sensible thing, because certainly in terms of data collection and follow through, if you've got the right read codes and the right identification flags from the outset, you can then track the impact on, frequency of visits, hospital visits and all of that kind of stuff, medication management, all sorts of ancillary measures that you could then say we're actually looking after the health and well-being, particularly of the old frail carers, but also, identifying frequency of visits and so on. And to do that consistently would give us a much better body of evidence about what makes a difference.
Yeah, I think that could be quite exciting, actually. And I think the idea would be to use these barks as that test bed for this, because you're just doing so much and you're really in there.
Well, it would certainly add, I think, an additional practical dimension to what we're thinking of doing, Mike. But it would also give us a common platform for measuring, the impact by different CCG, local authority, different groupings, if you like, because everybody's going to be measuring the same thing. And so that would add and build the body of evidence and analysis that we would need to demonstrate our success.
Yeah.
Well, if I go away and just think that through a little bit, link that into Dave Ross, my national contact within the national team, and Rosie, and I will come back to you both on that. Is that okay?
Yeah, that'd be great.
That's fine. That's good.
Good. So we've got about 10 minutes left, because I know you two both got to go off and make a call with each other. Is there another focus for discussion that you'd like to have?
The other thing that I think is clearly emerging as a really good model of good practice is what you're doing in East Berks around your process of going through your new vision of care board through to your. So you haven't yet met with your health and wellbeing board, is that right, Mike?
No. So actually, our for Slough, there's been some discussion around this. Where there's a subcommittee of our board, which is a health PDG. It's a health priority delivery group.
Okay.
And they said actually that's a place where really the discussion and the sign up needs to happen, and then it'll probably go to the board for information and sign off, because it's that subcommittee really that all the the key partners are there. So yes, I've got it on the agenda for a meeting in January, where I'll write a short report and just be seeking to get people commitment to the MOU, but then appraising them on where we are with our our proposed project with the patients panel.
Right.
The kind of parallel scenario for WAM is that we don't have the group between our Health and Wellbeing Board and our Better Care Fund board that Mike has just described. So anything that is either funded by Better Care Fund activity or relates to carers is actually taken straight to that board for mandate, and then the recommendation to the Health and Wellbeing Board goes through from there. And we meet on a monthly basis. It's cross-functional. It's health and social care working together. So that's the body that supports, if you like, everything that we've been describing, and the recommendations up to the Health and Wellbeing Board would be automatic, if you like, from there. But I think one of the things that strengthens our respective positions is the importance of the fact that both Berkshire Healthcare Foundation Trust and the ambulance service and Frimley need to be co-signatories of that process. So we had in mind this kind of collective approach that says each Health and Wellbeing Board needs to sign something off, but we can build the engagement that links into the STP footprint by saying we've also got a lot of common partners that we need to communicate with, not 3 times over for the 3 East Berkshire CCGs, but actually once through this collaboration. And then that creates a much kind of more efficient way of being able to promote the carers work that we're recommending. So I think that will also find favour with not just our Health and Wellbeing Boards, but with the partners that we're asking to sign up.
Yeah, I think one of the difficulties you might likely to have, Marion, is about agreeing the priority areas. Because as I was saying just before you came on, we've said those 3, acute are GP, primary care, and young carers, and the acute wants us to kind of do it throughout the hospital, not just at those admission and discharge, and as I say, community health wants community and mental health as well, which are kind of quite big service areas, and we need to kind of chip off bite-sized chunks rather than trying to be all things to all people, because we can only kind of do a bit at a time.
Yeah,
so
no, I agree.
Some of those partners might not agree to how we want to prioritise. So it's about what I suppose might be with the support of our panel in order to help us do that, or just that we evidence why and how we're going to do these first.
Yeah. But also, I think that we can also present our panel as not being exclusively focused on our own priorities and agenda, but also being a collective focal point for some of those other partners if they are actually wanting to take forward initiatives to avoid duplication and to engage our support as well reciprocally. So I think that if there's one point of contact, it will help them to contact us as that one point of contact.
Yeah.
Can I just check out with you, because I wasn't quite sure, the patients panel, is that within acute trust? Is that what I was? No.
It's the 3 East Berkshire-wide CCGs patient engagement group. It's the 3 CCGs.
That's fine. That's reassured me, because I misunderstood and I thought if it's associated with an acute trust, it'll have a different.
Yeah, no, it is just and that's what we really are using them to focus on, as I say, the raising awareness and recognition in GP practices primarily.
And how does the voluntary sector organisations link in? Because again, on the call on Tuesday, the other person on the call was from a carers organisation, and they were just, it's their job. They were full of enthusiasm of linking in this case with primary care. But what's your experience so far working with those? Do you have a county-wide or similar carers?
No. Shall I just say for Slough, Marion? So we have in our voluntary sector, we've got a consortium. We've recommissioned all our voluntary sector service under a single kind of consortium, and we have a carers lead organisation, Crossroads, within that. But one of the things we are working with that consortium with is about social prescription process, and we're about to pilot that, and that would include kind of carers within that as well. So yes, being able to identify the carer and provide them with prescription onto a community navigator that will help them kind of access other services and indeed, the carer's assessment or what have you, depending on the need. But they're looking at doing a kind of well-being a plan, working with the people that referred through to the navigators. So they're kind of on board. But as I say, we've only really got together as an East Berkshire kind of leads group, but acknowledging that we now need to, expand out to our other partners and get them, into to discuss our ideas really.
Yeah. The parallel situation in Windsor, Ascot and Maidenhead and Bracknell is that through dint of circumstances, if I can call it that, and a late withdrawal from our previous carer support provider just at the back end of the last financial year, the ARC services, or Signal for Carers, actually provide carer services, carer support services, both to Bracknell and to Windsor, Ascot and Maidenhead. However, it's done through currently 2 separate contracts. So one of the things that we're doing behind the scenes as the commissioners is to actually try and reduce the amount of duplicated effort in terms of reporting, learn from each other. So actually we help the provider, Signal for Carers, to actually be as consistent in their provision across the 2 areas as possible. So we're kind of helping them work through that, but it's early days on that.
Yeah.
But the other link there is that through their kind of parent body, their parent body is also indirectly linked to Health Watch services in Bracknell and in Wham. And so Health Watch also have quite a role to play, I think, in terms of championing and advocating the support for carers and actually working alongside us. So that's something that we might be able to capitalise on in Bracknell and Ascot and Wham going forward. But clearly, we need to make sure that the synergy with anything that we're doing with our Health Watch that might overlap with or complement or differ from what Slough are doing.
That makes sense.
You've got just a few minutes, I think, before you two both have to go off as well. Kath, is there any concluding things you wanted to draw together or talk about further bringing together people, activists like yourselves? I know you, in fact, you work in the same room, which is it's an interesting coincidence. But one of the other purposes of having these web discussions is we can cross boundaries and learn from people 50 miles away. But anyway, Kath, do you want to draw us to a close? Say something at the very end.
Yeah, I think it's really encouraging to see the development and the progress and the pathways that you're working through to bring that sign up and that collaborative working to fruition, and really interesting to see that angle from the CCG through Sarah Fellas and that quality side. I just think it's a very, very good and interesting model. So in terms of actions for me to go away with, it's around the recode. I think that's where I'd like to really focus a bit. And I had linked in with Runnymede with Julian through my other part of my job with NHS England is CQC oversight support. So we are meeting regularly with Runnymede whilst they're in a period of action and improvement before they are re-inspected next year. And as you said rightly, Marion, carers came up. So they are a really good example of a practice that's going to be really engaged in piloting something and trying something out. So I will follow up on that recode piece of work, and I think it'd just be really great to keep in touch and just to track the progress, I think, because what would be great if you're happy would be to sort of case study this, I think, for to put out across the South, if you're happy to do that, just in keeping it quite simple and model-based, but it would be a really good case study.
I'd be happy with that. Yeah, that'd be good.
The only other thing I was just going to, a quick one just to add on, when you mentioned with those areas, Mike, at the beginning around the sort of East Park group and acute being mentioned as an area, and I'm sure you're well aware of this, but hearing from other areas what's been working well in acute settings with regards to carers, which is that quick win of the carer passport
thing. Okay.
And how that has quite, so because what I have been having discussions with is this idea about, so in primary care, we pick up the carer, we identify the carer, okay, we have them coded on the system. But what happens then between primary and secondary care? And I've had fed back to various people that there is too much of a challenge to be suggesting that primary care can be passing that information through to secondary care, because there is so much information that goes with a patient when they are in secondary care, that to add that detail of a carer is going to be not feasible. And so it's about looking at however, we do need to recognise that there's a situation where a carer may turn up unplanned in acute care, or a carer may be needing to support the person they care for turning up into acute care. But if you take the scenario of a carer arriving in acute care in an unplanned way, then what systems are in place to identify that person as a carer and ensure that the person they care for is safe and well? And that's where the carer passport or carer ID card comes in.